All right, the next topic we're going to talk about for respiratory problems is going to be our lung cancer. So lung cancer comes in a couple different flavors. There's our non-small cell lung cancer and our small cell lung cancer. Non-small cell lung cancer is by far our more survivable of the two. Sometimes we just call this large cell lung cancer, but this is the one that we can treat. Small cell lung cancer only has about a 6% 5-year mortality, which is significantly lower than our non-small cell. So it's a much more lethal version of the disease. And we'll talk more about what survivability means here in just a minute. Metastasis can definitely be a thing for patients with lung cancer. So what we know is that it can spread in a few different ways. One is through direct extension, which means it invades a surrounding tissue. So the lung cancer tumor size can invade surrounding organs or body systems, causing infiltration through the circulation and also through the lymph system or other ways. It tends to metastasize to the liver, brain, bones, and kind of those areas. That tends to be where it metastasizes. So between the types of lung cancer we have, so our non-small cell lung cancers is the blue in our little circle chart, which makes up 85% of all cases. Our small cell lung cancers are the red space, so a significantly smaller proportion of patients who have lung cancer have small cell lung cancer. So that's, even though it is more lethal, it is much less prevalent, which is a good thing, or a place to draw hope from for patients. Etiology, so the way that patients get lung cancer, smoking. In nursing school, we have to say, like basically with every lecture, don't drink, don't smoke, tell your patients don't drink, don't smoke. And here we are doing exactly that. So cigarette smoking is associated with 80 to 90% of all lung cancer cases. We do have our obligatory picture of nasty lungs. So 3 guesses which one the smoker lung is. There is a link in here. The lady working with these actually inflates them. So you can see the difference in how they ventilate between a smoker's lung and a healthy lung. Definitely recommend checking that out. It's pretty disgusting, which always gets everybody excited. So that's a fun link. Secondhand smoke, thirdhand smoke are also a component of smoking exposure. We do know that a lot of the carcinogenic properties are in the exhaled smoke, so we do need to watch out for that. Pipe and cigar smoking, we cannot, these are not health foods. There's no such thing as healthy tobacco products in this country. So none of those are okay, none of them are healthy. Anytime you're putting something in your lungs that doesn't look like air, that is not good for your lungs. That means there's particulates in there that may stick to your lungs, causing this kind of an appearance. It's not good. So we do want to counsel our patients on that. Marijuana is becoming a thing. We have no idea what marijuana use looks like as far as its prevalence of causing lung cancer, things like that, because it's still a controlled substance, we can't directly study it. But we do hope to decriminalize that federally so we can start studying the effects. One of the things we do know is about vaping. As of last year, around Thanksgiving time, 2019, we did have a new disease called EVALI, which is e-cigarette and vaping associated lung injury. So we know that there's like another round of COPD or severe lung injury associated with those e-cigarette and vaping products. There's a chemical in there, it's an oil-based chemical that we're thinking is what's associated with the lung injury from people who use those products, but we don't know for sure. But we do know that the heavy use of those products does lead to lung injury, but we don't know specifically how it relates to lung cancer yet because we just don't have those longitudinal studies. Other carcinogens that we do need to be aware of, asbestos, radon. Radon is actually a big thing here in Colorado. It's a natural element that's leached from the ground. So people in older homes with basements that aren't well sealed are at very high risk for radon exposure. So it's definitely one of those things we want to counsel patients about here in Colorado. So survival rate. So lung cancer survival rate, it's not great. And this is for all types of lung cancer. So breast cancer, colorectal, prostate cancer are all significantly more treatable than lung cancer is. But let's talk about what survival rate really means for just a little bit. This is a survival rate graph. So this is 5-year survivability for non-small cell lung cancer survivors. It's old data, it's from 2000 to 2011, but I don't imagine things have changed very much because we don't have a lot of new treatments for that type of cancer. So what that looks like is after 6 months, 65% of patients are still alive. After 1 year, 44% of patients are still alive. So even though we say there's a 5-year survivability, only 4% of patients make it to 5 years. More than half are dying before 6 months. So we have to be very careful how we talk about survivability of disease and prognosis with our patients and what that really means. Because most patients will not survive past 2 years. A very small percentage of patients are going to make it to that full 5-year mark. So that's what survival really means. So it's pretty scary when we start seeing how that kind of really stretches out, but most patients do die very, very quickly when we look at the disease trajectory for these things. So lung cancer assessment, here's our big symptoms. Unfortunately, lung cancer, kind of like TB, is one of those diseases that we really don't see a lot of symptoms until it's very, very advanced. Cough, shortness of breath, wheezes, chest pain, coughing up blood is really the hallmark symptom. It's really the reason most patients seek health care when they start to have these presentations that are suspicious for lung cancer. But cough, shortness of breath, like you go run too fast, you can cough and be short of breath. It's not very descriptive. But coughing up blood, that is definitely a concerning symptom. People should not be coughing up blood. That's a bad thing. But that triad is highly suspicious. So we want to try and obtain our subjective and objective data. So as much description from our patient around their coughing, around their shortness of breath, and our objective data, can they reproduce some bloody sputum? Like that's very suspicious for the presentation of lung cancer. We also want to assess the patient's level of anxiety. Most people are pretty in tune that if they're coughing up blood, something bad is going on, so they can be really afraid of what that might mean for their health and for their future if that starts happening. We also want to assess the patient and their family members for what is going on. Do they understand the diagnostic tests, diagnosis, treatment options, prognosis, also a big one. Make sure they understand survivability, things like that. So for our assessment behaviors, we're really focused in on our respiratory exam. We want to know what their lung sounds are. It's a lot of interview around their shortness of breath, their coughing, and we definitely want to try and collect sampling of any bloody sputum that they're able to produce. So a lot of respiratory assessment is where this is focused. And then a close second is really our psychosocial assessments. Do they understand what's going on? How are they feeling about that? How are they coping with a potentially devastating diagnosis? Early symptoms that patients may present with. Honestly, lung cancer tends to be asymptomatic early on. It silently spreads because most patients don't notice any acute change to the physiology of their lungs. It's not an innervated organ, so they're not going to feel that kind of expansion of tumor inside their lung. The earliest symptom can be that hemoptysis. As that tumor expands and starts breaking blood vessels, that's usually when they present, and that's usually one of the first symptoms that they start really noticing. Chest pain can be present, dyspnea, so that shortness of breath can absolutely be a thing. But early symptoms do tend to be very kind of non-descriptive or non-focal, so it's very difficult for us to tell. Late symptoms, We start to see a lot of late symptoms that are consistent with a lot of different types of cancers. Cancer cells or tumors tend to be very energy demanding on the body. So we do tend to see a lot of muscle wasting, fatigue, those types of symptoms. So anorexia, weight loss, fatigue, dysphagia, those are common things with most advanced cancers. Things that are specific to the lung cancer type of thing, pleural effusions, which we're going to talk a lot more about here in a little bit. Dysrhythmias, tamponade, meaning there's bleeding into the pleural space, the cardiac space. Again, it's kind of the large scale presentation of that hemoptysis. So again, it's like a more severe version of our early symptoms, but they're really not like, oh, that's a symptom of lung cancer. It's really kind of generalized stuff that can be like, well, it could be nothing. So a lot of patients do present very late in the game with lung cancer. They have fairly advanced disease usually by the time they're seeking health care. For the medical diagnosis, how that happens is our first line of kind of intervention to help guide our diagnosis is interview. It's just talking to our patients. So their H&P, what symptoms brought them in, how long have they had them, whether or not they're getting worse or better, have there been any appetite changes, and then we want to start getting really pointed. Do they use tobacco products in any way? Smoking cigarettes, cigars, pipes, chewing tobacco, anything. Any of those reasons we want to be really cognizant of. And then are they around secondhand smoke? After we assess their risk of tobacco exposure, then we start looking at environmental factors that could contribute to lung cancers. Things like asbestos and radon are a couple of those really big ones. But our first line intervention or diagnostic is interview. It's just talking to our patients and getting a sense for this. Because if they've had persistent coughing, shortness of breath, fatigue, and hemoptysis for a series of months, that's very, very concerning. If they're presenting with their first episode of hemoptysis, it's not as concerning, but the longevity really does dial up the level of concern that we have when we're talking with those patients pretty quickly. Our second line of diagnosis, our second level of intervention, is we're going to want to look at it. We want to see it in their body. So we'll do chest x-rays, and that slight shading right there is the lung cancer in that patient. It's very difficult to diagnose lung cancer in patients via x-ray. If we can see it on x-ray, usually that means it's a pretty large tumor that's already pretty mature. So they're pretty advanced disease process by that point. CT scan is this one right here. Again, we're looking at this little shaded area as our positive for lung cancer. And radiologists are going to be the ones who diagnose this. We don't do that. It's actually quite rare that we ever see the raw radiology images. An MRI, so here's a lung cancer, and we can actually see kind of some of the streaking coming out of there. That is our tumor for a pretty advanced lung cancer. And the other one patients can get is a PET scan, which is a positron emission something or other, but it causes high blood flow areas to light up. And by light up, I mean exactly that. They really light up. So that is a lung tumor right there. These aren't all the same tumor. These are all different tumors in different patients. But just to show you guys the different scans that can be done and what those would look like if they were positive for a lung cancer. Confirmation, so definitive diagnosis, is always done through biopsy. So the H&P, the interview component, is suspicious. The imaging, chest x-ray, CT, MRI, PET scan, that's concerning. We don't get really like this is lung cancer until we get a piece of tissue from their lung, look at it under a microscope, and determine, and by we I mean a pathologist, that it is abnormal large cell or abnormal small cell lung cancer. So we really do want to see the cells in order to give that definitive diagnosis. That can be done a few different ways. If it's a very advanced tumor where there's a lot of hemoptysis being produced by our patients, we can get that from sputum cytology, because every time they're coughing, they're shedding off layers of the tumor with it. But that's really for very, very large and invasive tumors into the airway. Direct needle biopsies, where we take a very long needle, and usually they do this with a CT scanner, so they can guide it in with the CT scanner and excise a piece of that tumor. The most common one is VATS, which is a video-assisted thoracoscopic surgery. It's just a VATS procedure. These are critical care procedures where they go into a patient's thorax to excise a piece of tissue. It is a minor surgical procedure, but because we're dealing with the lungs, which is next to the heart, and a lot of vasculature, this is a pretty critical procedure that patients can have done. But those are the ways we're going to collect a biopsy to confirm diagnosis for lung cancer. Once we get that sample and we confirm it's lung cancer, then we're going to look at staging. So staging exists in 3 different categories. One is based on the primary tumor size. So the primary tumor would be the one that they've seen on radiology studies, whether it's MRI, PET scan, CT, whatever the best visualization may be. Then our next kind of phase or category is lymph node involvement. How much spread of abnormal cellular material has made its way into the lymphatic system. And then the final one is metastasis. Do they have metastasis to other parts of the body, meaning spread to other parts of the body, or not? So patients, this is an important thing to kind of consider, is patients can have lung cancer in their liver, because it's all about what type of cell is causing the tumor. So their primary cancer might be lung cancer, but the metastasized tumor might be in the liver. So we always need to know what is the primary type of cancer whenever we're talking about tumors in patients. What you'll usually see in documentation around staging is something like T2N1M0 will be that combination that gets listed out in the documentation, which corresponds to whatever their full staging is. So nursing diagnoses around patients with lung cancer, a lot of pretty scary stuff. So hopelessness, because most people know there's not a high survivability for lung cancer. Most patients know that by the time they're presenting, they probably have very advanced disease. So hopelessness can absolutely be a thing. Impaired gas exchange can absolutely be an issue, especially with highly invasive tumors that are obstructing bronchioles or closing off part of the lung from being able to perfuse oxygen. Absolutely a concern. Risk for activity intolerance kind of goes along with the impaired gas exchange. If they're not able to breathe very well, they're not going to be tolerating activity very well either. Also, the more activity they do, the more coughing and kind of hemoptysis they can present with. So also a very concerning presentation. And choose your own adventure. What other nursing diagnoses do you guys think? The plan, so the medical plan for these patients is the goal of all medical plans is to eliminate disease. When we talked about TB, the medical plan is give antibiotics to eliminate disease. When we talk about lung cancer, we want to eliminate disease. For cancers, we have this kind of trifecta of things that we do for lots of different types of cancers to try and cure them. So the first thing we do is surgery. We want to cut out the cancer. Patients can have several different types of procedures to remove sections of the lung or the entire lung, depending on how invasive the tumor is. Anytime we're doing surgery on a cancer area, surgeons are going to excise tissue until they get what's called clean margins. Margins meaning the last layer of tissue that they cut out did not have any presence of abnormal cellular material. So a lot of times the surgeries that take place for advanced cancers, a pathologist will be in the OR analyzing the tissue samples as the surgeon is doing surgery on those patients. Next one is radiation. This is where we can expose a patient to localized radiation, which can destroy tissue cells in a specific area. And we want to do that to the tumor or the area around the tumor to make sure that we've really kind of destroyed all those cancerous cells. One of the big things we got to look out for with patients getting radiation is they can actually develop a skin burn or a sunburn on their skin above where the radiation was going into their body. So for patients getting a lung cancer, say I was getting radiation right here on my body, the skin right there would be sunburnt. So we do want to advise patients to take care of that skin and make sure that they're protecting it from damage. And then chemotherapy. So chemotherapy is chemical agents. Most chemotherapies are designed to attack rapidly reproducing cells, which cancers are. So they'll attack all rapidly reproducing cells, which includes hair cells, things like that. That's why patients tend to lose their hair on their whole body when they go through chemotherapy. This can be done inpatient or outpatient, depending on the acuity of the patient. So we really do want to see how they're doing, and we always want to get patients into an outpatient setting whenever possible, especially for chemotherapies, because this can be another long-term treatment that patients may get for weeks or months after these initial therapies are completed. So the nursing plan. Nursing, our big thing is health promotion and patient experience of disease. So what we're really looking at is how do we promote the best quality of life in these patients that we can. We want to tell our patients, if they are smokers, maybe avoid smoking. That doesn't mean they have to stop smoking, because at this point, we want to promote quality over all else. Right? So if it's more of a fight to quit smoking, we want to try and negate that as much as possible, try and improve their respiratory system as much as we can. We want to promote smoking cessation programs. Some common ones that come to mind are like the Quit Line for Colorado, which is a free smoking cessation resource that every citizen of Colorado has access to. And they can help provide nicotine patches, nicotine gum to patients, to help them with smoking cessation. Other things that we want to do specifically while patients are undergoing treatment is acute intervention support. So whatever the medical intervention that is happening, we want to support our patients through that. That can be support during diagnostic evaluations, because they're going to have a lot of testing being done, which can be pretty frightening. So we want to make sure that patients are prepared for whatever their next step is, so they can manage the expectations around those studies. And monitoring for side effects, especially when they start getting into chemotherapy, radiation, surgery stuff. We want to make sure they're ready for what are the side effects of a lobectomy. Shortness of breath is going to become problematic for them. So we do want to make sure they're aware of those types of therapies and the side effects of them. And methods to reduce pain. So there's going to be lots of pharmacologic methods that are going to be applied to these patients, but we also really want to encourage supplemental methods of pain reduction, such as guided imagery, meditation, music therapy is actually highly effective, aromatherapy, other types of adjunctive therapies that can enhance the effect of any other pain medication that they're doing. Our dependent interventions is our medications. It's our chemotherapy, it's our radiation. Those are the dependent interventions that we'll need to manage for our patients who have lung cancer. So for implementation, sympathy and empathy. It's a really big differentiator that we need to understand. One of the things, so empathy is feelings of pity or sorrow for somebody else's misfortune. It's kind of a douchey way of saying it. But the idea of sympathy is that it's a pretty negative emotion for everybody involved. We never want to practice sympathetically, because part of the act of practicing with sympathy is stating that your experience of disease is exactly the same as what I already know. So it doesn't really matter what you're going through because I already know it all. So it's very dehumanizing and depersonalizing for the patient to experience a sympathetic response. The other traumatic thing that happens with sympathetic responses is that what we know from the research around healthcare providers who practice with sympathy is that it tends to evoke a lot of personal feelings around that issue. So when patients talk about lung cancer diagnosis with their patient in a sympathetic way, they have to conjure back all the other patients that they've taken care of with lung cancer and all the challenges they've gone through. So it can be very de-identifying for a patient, like depersonalizing, and also reliving a lot of personal trauma with those sympathetic responses. And what we know is that the more people practice with sympathy, the more likely they are to experience burnout in the healthcare profession. And this is across all professions in healthcare. Physicians, physician assistants, nurse practitioners, nurses, CNAs, MAs, everybody in healthcare. Empathy is very different. Empathy is the ability to understand and share feelings of someone else. So it's the idea that I don't need to relate a patient's unique experience to something I've experienced. All I have to do is understand what they're telling me. So they own their disease. I don't have to relive any past trauma that I've experienced emotionally, psychosocially, from caring for other types of patients like this or family members who have had this type of disease. Instead, I can focus on what the patient is experiencing. You know, the way I kind of like to simplify this is practicing with sympathy is kind of like telling them, well, your turd sandwich, I know, it's gross, but we're going to get through it, right? So your turd sandwich sucks. Empathy is like, how do I make that turd sandwich taste a little bit less bad? You know, what can I do for you to help us get through this? You know, how do I help you to have a better experience with this reality that we're facing? And always, always, always discuss concerns with patients. If there's any concerns that you have about course of treatment or advocacy for patients, talk about those with patients. Address as many things head on as possible, and that's a way to avoid burnout. We can actually reduce the experience of burnout by focusing on empathic reactions to what patients are going through. So for evaluation, what are our expected outcomes that we've identified? We want complete resolution of the disease, right? For any patient that shows up with cancer, we would love to be able to take away their cancer. But is that realistic? What's their survival? How advanced is their disease? One of the big things we need to talk about is what are their values around advanced disease and chronic disease management? Is it appropriate to talk about palliative care, hospice care, those types of things, or not? So we want to be very sensitive to those conversations. What about pulmonary function? Anytime somebody has surgery, especially pulmonary surgery, we want to set the expectation that we're not going to be returning to normal, but we need to identify what the new normal is. You know, redefine what normal means to our patients in the context of this new intervention and this new disease that they're dealing with. And then we want to look for the absence of complications. So if they're having surgery, we know what the predictable complications of surgical patients are. We want to avoid those things as much as possible. And you guys are going to learn all about those in the peri-op lecture. And then what's realistic? You know, every lung cancer patient wants to be cured in 6 months, going to Disneyland, on a cruise, living their best life. Is that realistic? Those are the questions we have to ask. And then we have to talk about what are the values that they have. What do they want to get out of the next 6 months, out of the next year? What are the things that are important to them? And have those difficult conversations with our patients to get them thinking about how to prioritize what they need to achieve in their life. So that one was a downer. Sorry. On to the next one.